Hello, everyone. All right. I'd like to welcome you on behalf of our panel and KDIGO. It's a pleasure to be here at the ERA. I'm Brad Rovin, and I'm co-moderating this with my colleague and friend Vladimir Tesar. So what we have planned for you today is a nice discussion on the KDIGO 2024 updates for the Lupus Nephritis Guideline. And what we'd like to do is really have a very brisk discussion with the audience. So please submit questions and participate, because we hope to have an engaging discussion after the three panelists are done. We're going to make this a case-based presentation. And these are us. These are our panelists. You're going to meet them individually. Okay, here we go. These are the official objectives, but we all know what KDIGO is. We like to talk about guidelines on how to manage different glomerular diseases. This is lupus nephritis. We have had a lot of traction recently because of all the new interest in drug development, and that's why we have an update to the guidelines, which came very quickly after a 10-year gap for glomerular diseases. We made the guidelines, and then right away, within 2 years, we made an update. Now, let's all remember why we're here, and that is to improve our care and management of patients with glomerular disease, and in this session, of course, lupus nephritis. And so to kick us off is Jeanette. And Jeanette is going to talk. Jeanette is a patient with lupus, and she is the chair of Lupus Europe. And she's going to talk about her travels through this disease and give us the perspective that we need when we talk about the management of the disease with all the new drugs. So Jeanette, welcome.
Thank you so much, Brad. Brad? Clicker? Thank you. Yes, so thank you so much, and thank you to the organizers for inviting me today to give you a patient perspective, because that is, after all, why we are all here, because of the patients. So I have no direct disclosures. I want to start by giving you a bit of background information on myself. So I have a master's degree in German and philosophy. I was a fitness instructor during my studies. I led a very active lifestyle, as you can see. I was a teacher at higher education, and I had a dream of starting a family. Now, this is my nephew, it's not my own child. I applied for a PhD position during the summer of 2011, and I got married to my wonderful husband in 2011, in August. So during our honeymoon, in Bali, a wonderful place, by the way, I experienced my very first big flare. I had multiple organ failure, and I ended up in intensive care. Here, I was diagnosed with SLE, and from then on, my life changed completely. Now, these are some of the symptoms I experience regularly. So pericarditis, pleurisy, CNS symptoms, rash, hair loss, chilblain, recurring infections, mouth ulcers, bruises, fatigue, joint pain and swelling, Raynaud, and so on. I could continue all day. So part of my treatment is taking 48 pills a day, every day, and that doesn't include pain medication, to have injections every week and infusions every 4 weeks. Now, unfortunately, I'm a refractory patient, which means I have frequent hospitalizations. I have to maintain a physiotherapy 3 times per week, otherwise I won't be able to move. I've had 8 major surgeries since diagnosis, including 5 in the spine. I often have hydrocortisone injections in the joints. I have to keep up on my vaccinations to keep them up to date, so flu, pneumonia, COVID, and so on. I have to maintain sun protection at all time, so I never go anywhere without an SPF of at least 30, and in the summertime, 50 plus, all the time, and always wear hats outside in the summer. I have blood tests done every 4 weeks. I have scans, MRIs, CT scans, X-rays, examinations, biopsies, and lumbar punctures. So, which consequences has it had for my life? I had to go into early retirement. I went from very active days where I did 2 to 3 hours of exercise a day to very inactive days where I do 30 minutes approximately. I gained a lot of weight, around 50 kilos. You can't see it on me today because I had to work really, really hard to lose that weight. So comorbidities like antiphospholipid syndrome and osteoarthritis meant that I had to give up having children, and I ended up in a wheelchair. I was supposed to start that PhD position in September 2011, but I realized I had to give up my lifelong dream of having a PhD. Now, the heterogeneity of the disease means that it's necessary to become an expert in my own disease. This is the best way I can take care of myself. And this complicated care of an SLE patient often takes more than one healthcare professional. And if the patients are lucky, they can work closely with a multidisciplinary healthcare team, including rheumatologists, nephrologists, nurses, and other specialists, to monitor the condition and adjust treatment as needed. This also means that we need to juggle specialties and treatments. In my case, 13 different HCPs. Here you see some of them during one of my consultations. This multidisciplinary team, of course, requires a good coordination, which should not be put exclusively on the patient. It also doesn't help when physicians have different opinions about which medication to use at which time. Most patients have a love-hate relationship with steroids. They help with our symptoms, but at the same time, we know that they have a lot of bad side effects, especially on the long run. Many lupus nephritis patients hate to take MMF. It causes nausea and a lot of other nasty things. Cyclophosphamide, it's sort of a boo thing. It's one of those drugs that often work really well on lupus nephritis, but patients are afraid of the side effects, especially fertility issues. Which brings me to the complicated matter of family planning with lupus nephritis. Opening up the topic in the first place is very difficult. If the patient doesn't bring it up herself, it often won't be addressed at all. The updated guidelines emphasizes the need for pre-pregnancy counseling, but it doesn't happen at the moment. As you know, to avoid lupus nephritis flares during pregnancy, physicians need to find a balance between active disease and medication choices to avoid fetotoxic drugs like cyclophosphamide, MMF, methotrexate, warfarin, and so on, while also avoiding adverse pregnancy outcomes like preeclampsia and preterm delivery. This makes the patient feel very uneasy, and here it's really needed to have a good communication. No two lupus patients are the same, but here are some of the challenges that lupus nephritis patients may face during their travel. Shock and denial. Initially, patients may experience shock and disbelief upon receiving the diagnosis. Some individuals may deny the reality of the situation as a coping mechanism, especially if they were not expecting such a serious diagnosis. They ask questions like, why me? And then there's the unpredictability. When will I have a new flare? Patients may experience a range of emotions, including fear, sadness, anger, and frustration. Dealing with the uncertainty of the disease and its potential impact on their health and quality of life can be emotionally distressing, especially with lupus nephritis, where you don't actually feel the symptoms until it's really bad. The guidelines primarily focus on medical management and do not sufficiently address the emotional and psychological impact of living with lupus nephritis. The Lupus Europe, we did a research that shows that in 1 out of 2 patients, all SLE patients face depression or anxiety. At the same time, it is undertreated. And if you look at lupus nephritis patients alone, the number is even higher. Many patients feel empowered by educating themselves about their disease. They may seek out information from healthcare professionals, websites, support groups, and literature to better understand the condition, treatment options, and prognosis. Google is the first thing a newly diagnosed patient will do, even if we tell them not to do it. Answers they find here are often out of date and not trustworthy. They need reputable sources. Support from family, friends, and peers who understand the challenges of living with a chronic illness can be invaluable. Connecting with others who have similar experiences through support groups, online communities can provide a sense of belonging and validation. Often they turn to patient organizations for validated information. A good example is the lupus100.org website created by Lupus Europe, where you can find the 100 most frequently asked questions about lupus and their respective answers, created by lupologists and patients in Unity, and translated into 14 languages today, with more to come. The material is not only useful for patients, but also, in many cases, GPs, nurses, and even HCPs can learn from it. The local or national patient organizations are always a good source of information for patients and a place you can refer them to. Regular medical follow-ups and adherence to treatment plans are essential for managing lupus. Patients sometimes face the difficulty of having two different HCPs disagreeing on which treatment you need. One might tell you to stop taking steroids because they're really bad for you, and the other says you need to keep on taking steroids, otherwise you'll go into a flare. So who should we believe? The only way to solve this is by having them work together and communicate with each other, which unfortunately doesn't happen a lot today. The guidelines provide a standardized approach to treatment, but patients often need a more personalized plan. Factors such as individual patient preferences, comorbid conditions, and specific lifestyle needs should be integrated into the guidelines. Although new recommendations encourage early use of biologics like belimumab or voclosporin for lupus nephritis, there are issues with actually getting access to them. Lack in accessibility and affordability means that only 11% of European lupus patients are treated with biologics today. Here, patient organizations have a responsibility to educate patients to participate in HTA deliberations and also lobby for better access on a national level. The guidelines do not address the impact of treatment on patients' quality of life. This includes managing side effects, balancing treatment efficacy with quality of life, and providing information on lifestyle modifications to help patients maintain a better daily life. Patients often need to make significant adjustments to their lifestyle to manage lupus nephritis effectively. This may include changes in diet, exercise, stress management, and medication adherence. Most patients will need to reduce or modify their work and/or social activities to accommodate their health needs. Having SLE or lupus nephritis equivalates a full-time job. Physical exercise has been clinically proven to reduce fatigue and seems to have a beneficial effect on disease activity and pain. But try telling that to a lupus patient who suffer from fatigue. That's why Lupus Europe has developed an exercise program done by patients for patients. Patients develop various coping strategies to deal with the unpredictability of lupus. This may include practicing mindfulness and relaxation techniques, engaging in hobbies and activities that bring joy, maintaining a positive attitude, and seeking professional counseling or therapy when needed. Some patients become advocates for themselves and others living with lupus nephritis. They may join patient organizations, raise awareness about the condition, and advocate for improved access to healthcare services or assist in research projects. Encouraging patient involvement in decision-making and advocating for their own care is crucial. The guidelines could provide more advice on how patients can communicate effectively with their healthcare providers, or the other way around, and be active participants in their treatment planning. Now, I would like to finish with my own case. After receiving my diagnosis in 2011, I felt like I had to act. The way I chose to do that was by joining the Danish Lupus Group in 2012. I attended my first Lupus Europe convention in 2014. Here, I realized that I needed to work on an international level if I wanted to make a difference. I worked quickly, and I joined the Lupus Europe board in 2015. In 2017, I became the chair of Lupus Europe. I completed the UPATI patient expert course on medical research in 2018, which led to the creation of the Lupus Europe Advisory Network in 2018, where we have 25 active and engaged patients today. Today, I'm the leader of the Patient Advisory Network, matching patient experts with research projects. I'm a patient representative in Juan Reconet. I'm a trustee in the Danish Lupus Group, EULAR PARI committee member of the Action Council on Patient Engagement in Rheumatology Research, co-author of the latest 2023 EULAR recommendations on SLE, and I'm currently working on an CME accredited education program on patient-doctor communication with Lupus Academy. Educated patient representatives can be used for many different things. I have been a part of guidelines, white papers, 29 scientific articles, patient journeys, creating surveys, patient councils, patient charters, and so on and so on. So make use of us. That's what we are here for. Thank you for listening to the patient's point of view, and I look forward to having a good discussion.
So I think we'll all agree that was a pretty compelling story. And what resonated with me, among many of the things that Jeanette brought up, was the idea of physicians disagreeing on management. And of course, the KDIGO guidelines, and just to be clear, we don't want the guidelines to say this is the way you have to treat everyone. It should be a personalized therapy for each patient. But the idea, of course, is to get people started in the right direction. And so with our first presentation, I'd like to introduce Dr. Juan Manuel Mejía from Mexico City. I'm sorry I mispronounced again. And we're going to do, as I said, a case-based presentation. So get your phones ready to take the QRS codes and participate in this, please.
Okay, thank you. Wonderful talk. So in the next two presentations, we'll go through a case-based discussion of the 2024 updates in the KDIGO guidelines. These are my disclosures. So please have your phones ready to scan for the QR codes. Once they appear in the screen, we'll read all the options, and they will not appear directly in the phone, but they will appear after we click on the Start Voting button. So our first clinical case is a 28-year-old female. She was diagnosed with lupus in January 2024. She's currently under methotrexate and prednisone, and she has 2 weeks with progressive edema, malar rash, fatigue, malaise. She has a body mass index of 34 kilograms per square meter, normal blood pressure, malar rash, and symmetrical edema up to the knees. Her laboratory tests show normocytic anemia, relatively preserved kidney function with an eGFR creatinine of 103 ml per minute, nephrotic syndrome with low serum albumin, 6.1 grams per day of proteinuria, low complement C3, and high anti-double-stranded antibodies. And she was performed a kidney biopsy that showed class 3+5 lupus nephritis with an activity index of 6 points and a chronicity index of 0 points. So I just want to underline some characteristics. It's a young patient. She has obesity and a nephrotic syndrome. So our first question, and you can scan the QR code with your phones, is which of the following maneuvers would you perform at this moment? And you can select all the ones that you can consider. So option A is start hydroxychloroquine at 5 milligrams per kilogram. Option B, start IV methylprednisolone pulses. Option C, oral glucocorticoids at 1 milligram per kilogram. Option D, oral glucocorticoids at 0.5 milligrams per kilogram. And option D, calcium and vitamin D supplementation. So we go to start voting, okay? Right-click, okay. So you will see the options is hydroxychloroquine DA, IV methylprednisolone B, oral glucocorticoids 1 milligram per kilogram C, or 0.5 milligram per kilogram D, and calcium and vitamin D supplementation. Okay, so we can see that. Okay, I can see the number. Okay, most people will start on IV methylprednisolone, hydroxychloroquine, calcium and vitamin D, less people with glucocorticoids at 1 milligram per kilogram. So let's go, okay. Okay, so these are my considerations, pretty similar to many of you, and we'll go through these considerations based on the 2024 update. So since 2021, KDIGO considered to add a table of all non-immunosuppressive measures we need to use to minimize the risk of complications. And those include anti-proteinuric measures, cardiovascular risk assessment, infection risk assessment, assessment of bone injury, ultraviolet light exposure, assessment of fertility issues, as Jeanette mentioned, contraception, unplanned pregnancy, and cancer. And the 2024 update, I'm not going to go through all the table, but the 2024 update added SGLT2 inhibitors as an antiproteinuric measure, especially in the chronic phase of the disease in patients with CKD, and of course, vaccination against any agent of concern in the public as COVID-19. The second thing we have learned from rheumatology is the power of antimalarials. Antimalarials have a lot of observational evidence supporting their protective role in systemic lupus, and down you can see the specific studies in lupus nephritis. So it's now a recommendation to try to use an antimalarial in all our lupus nephritis patients unless contraindicated. And one of the last studies, this is a cohort of more than 400 patients. You can see in the purple line that antimalarial use increases the rates of response to therapy, decreases the incidence of kidney flares, and of course with this prevents progression to kidney failure. So let's move to a different field, and that is glucocorticoids. And glucocorticoids, we love them, but we hate them, as just Jeanette said. So we've been trying to go to lower doses or faster tapering. As you can see in the yellow line, in the Bliss-LN study, it was a fast taper. And in the orange line, the Aurora 1 study, when we used IV methylprednisolone, then we could start with lower dose of glucocorticoids. But it is also true that we have no clinical trials for the use versus no use of IV pulses. For the initial doses, just small clinical trials, no trials for tapering or optimal duration. So with no hard evidence, KDIGO decided to add these practice points. These are good clinical practice points. And KDIGO suggests that you should try to decide if your patient is a candidate for a reduced dose glucocorticoids. This is reduced dose, not low dose at all. So starting with IV pulses, followed by 0.5 to 0.6 milligrams per kilogram starting dose of prednisone, and then go down below 5 milligrams by the third month. And this is pretty similar to EULAR guidelines. You can see the EULAR guidelines added SGLT2 inhibitors as an option for management of chronic kidney disease, and EULAR guidelines added hydroxychloroquine recommendation and reduced dose glucocorticoids as a starting dose of 0.3 to 0.5 milligrams per kilogram per day. Okay, and the other decision here in this patient leads to the second question. So what scheme would you consider for initial immunosuppression? So you can scan the QR code, and the options here are A, IV cyclophosphamide following the Lupus Nephritis trial. The option B is mycophenolate mofetil at 2 to 3 grams per day. Option C, IV or subcutaneous belimumab plus mycophenolate. Option D, voclosporin plus mycophenolate. Option E, none of the above. That is a different scheme. So we can start voting. Thank you. So you can see the options. A is cyclophosphamide, B, mycophenolate, C, a combined regimen of belimumab, mycophenolate, option D, voclosporin, and mycophenolate, option E, another different regimen. Okay, so most people would use mycophenolate as a starting therapy, of course, in combination with glucocorticoids, hydroxychloroquine, less people with belimumab and less with voclosporin. So let's see what okay, we close voting. So my consideration based on the 2024 KDIGO guidelines is a CNI combined with mycophenolate, and I will explain this decision to you. So the update now considers 4 immunosuppressive regimens as a first-line therapy, mycophenolate, cyclophosphamide, combination with a CNI mycophenolate or belimumab mycophenolate cyclophosphamide. And this, of course, is completely similar to the update of the Euler guidelines that now considers these 4 regimens. But the big question is, which one for which patient? And for now, we base this consideration based on sub-analysis of clinical trials. So as a practice point, KDIGO suggests initial therapy with an immunosuppressive regimen that includes a CNI, that is voclosporin, tacrolimus, or less recommended, but cyclosporin may be considered in some situations, may be preferred in patients with relatively preserved kidney function and nephrotic range proteinuria as our patient. And this is based on the results of Aurora 1 study. You remember this study, voclosporin added to mycophenolate in blue was superior to mycophenolate alone, in terms of complete response by 6 and 12 months. And the best effect of calcineurin inhibitors was a fast decrease in proteinuria, leading to more than 50% reduction in proteinuria in less than 1 month in more than 50% of patients. And this is a later sub-analysis in patients with proteinuria above 3 grams per gram of creatinine. And you can see at 6 months, the partial and complete responses went up. At 12 months, it was the complete response that led the difference with an odds ratio of 4.4. And as a safety issue, the eGFR was maintained for at least 3 years of use of the calcineurin inhibitor. So this is good, and this table was published in the executive summary that suggests that for the use of voclosporin or another CNI, we have to use with caution. If eGFR is below 45, this is because that was the criteria for inclusion in the Aurora 1 study. Caution with advanced sclerotic or fibrotic changes, especially good for patients with high levels of proteinuria where we want to decrease fast. Of course, is oral only, has not been tested in combination with cyclophosphamide yet to determine all their extrarenal benefit. And safety, it was safe, but of course, initiating a calcineurin inhibitor, we need to monitor blood pressure and acute eGFR variations. And voclosporin is not recommended in pregnancy, unlike tacrolimus and cyclosporin. So to close this vignette, the take-home messages are that before the start of immunosuppression, we have to consider all measures to minimize the risk of complications. We have to consider starting immunomodulation with hydroxychloroquine. Consider always using the lowest possible dose of glucocorticoids and an individualized selection of the best immunosuppressive scheme. I hope we can move to biomarkers, but for today, we base these practice points on sub-analysis of current clinical trials. And so the CNIs are suggested for patients with preserved kidney function and nephrotic range proteinuria as the case we observed. Thank you very much.
Okay, for our second vignette, I'd like to welcome Isabelle Ayoub from Ohio State to talk about a different patient.
All right, thank you so much for the invitation to give this part of the talk. Here are my disclosures. And we're gonna start with the second vignette, so please be ready and use your cell phones to vote and answer the questions. So this patient, she's a 35-year-old female. She was diagnosed with the SLE in 2018. At that time, she had also lupus nephritis, and she flared again in 2022 while on mycophenolate. Currently, in 2024, she's on Myfortic, 720 BID, hydroxychloroquine, and an ARB. She presents to the clinic reporting fatigue and foamy urine. On physical exam, her blood pressure is 130/80, and she has a little bit of edema. Her serum creatinine is elevated at 1.7 with a GFR of 40. Her serum albumin is slightly low at 3.6 gram per deciliter. 24-hour protein is elevated at 2.4 grams per 24 hours. And the C3 is low at 70. Anti-double-stranded DNA are elevated. A kidney biopsy was performed and showed class 4 lupus nephritis with activity index of 6 and already a chronicity index of 6. So the alarming signals here are recurrent lupus nephritis flares, a low GFR at 35 years of age, she's around 40 now, and already established chronicity index on kidney biopsy at 6. So the question is, what scheme would you consider for initial immunosuppression? A, intravenous cyclophosphamide, the Eurolupus regimen plus glucocorticoid. B, increase the mycophenolate dose to 2.16 grams per day in addition to glucocorticoid. C, combination therapy with belimumab. D, voclosporin with mycophenolate and glucocorticoid. And E, none of the above. Please use your cell phone to vote. So again, cyclophosphamide, increasing mycophenolate, using combination therapy, whether with belimumab or voclosporin. E, none of the above. All right, so the majority decided for C, maybe because the first case was D. But that's a good choice. So, of course, this is a preferred answer, but that does not mean that the other options are wrong, but the preferred is C, and let's go over why. So again, if we go over the updated KDIGO guidelines that were published in 2024, in addition to glucocorticoid, KDIGO recommended for active lupus nephritis 4 options, either mycophenolate or cyclophosphamide, or combination therapy using either voclosporin or belimumab. And in order to help us navigate these options in a specific scenario, practice points were suggested. So let's go over this one. A triple immunosuppressive regimen of belimumab with glucocorticoid and either mycophenolate or reduced dose cyclophosphamide may be preferred in patients with repeated kidney flares or at high risk of progression to kidney failure due to severe chronic kidney disease. And this is based on the BLISS-LN study that compared belimumab to placebo on a background therapy of mycophenolate or cyclophosphamide over 2 years of therapy. And it showed that the patient who received belimumab had superior response, whether primary efficacy renal response or complete renal remission compared to the placebo, again, through the 2 years of therapy. In order to better understand who would benefit from belimumab plus standard of care therapy, again, in the absence of biomarkers or pathways that would help us identify these benefits, we continue to rely on secondary or subgroup analysis from these clinical trials. So looking here at the effect of belimumab versus placebo by histology, by class of lupus nephritis, you can see that those with proliferative lupus nephritis or mixed proliferative plus class 5, they benefited from belimumab compared to placebo, but not so much class 5, whether in poor or complete renal response. What about the effect of belimumab based on proteinuria? And here they defined high proteinuria as 3 grams or above at baseline, or low proteinuria less than 3 grams. And you can see here that there is favorable benefit from using belimumab in those who had lower proteinuria, less than 3 grams. But those who had 3 grams or above did not benefit much from adding belimumab to standard of care therapy. What about relapsing versus a new lupus nephritis patient? There is favorable outcome in all, in particular, those who have relapsing disease. And our patient has already 3 relapses, and more relapses definitely will lead to further progression of kidney dysfunction and decline to end-stage kidney disease faster. So we want to use something that would decrease future relapses. And beyond the response to therapy in terms of remission, whether primary efficacy renal response or complete and partial response, the use of belimumab in addition to standard of care allowed to decrease risk of lupus nephritis flare for the future, no matter what the background therapy was, whether cyclophosphamide or mycophenolate, and no matter what the class was, whether proliferative, mixed, or pure. So even if belimumab was not that beneficial in class 5, in class 5 patients, they still benefited from decreased LN flare in the future. What about the eGFR slope? The use of belimumab slowed down the GFR decline per year. And you can see here that the eGFR slope is less steep in those who used belimumab compared to placebo with statistical significance. What about decline by 30 to 40% per year? The use of belimumab led to a slower decline by 30 to 40% compared to placebo. You can see the hazard ratio with statistical significance. So to summarize the benefit of using belimumab and who would benefit, what is the profile of the patient that benefit from that? It can be used in patients with CKD if their GFR is at 30 or above, because it may slow down the decline of GFR. In terms of histology, it's not really determined, but maybe pure class 5 might not benefit from it in terms of response, but they benefit in terms of decreasing LN flare. It is more effective in patients with proteinuria less than 3 grams per day. It may decrease the rate of flares. It is effective in combining it with mycophenolate, but there is uncertainty regarding its efficacy in combination with cyclophosphamide. That benefit did not reach significance. It could be because of sample size with the cyclophosphamide, or because the patient who received cyclophosphamide, they had more severe disease compared to those who received mycophenolate. It's a medication that we use as intravenous or subcutaneous. So if our patient is non-adherent to therapy, IV belimumab might be an option for them. In patients who have significant extrarenal manifestations in addition to lupus nephritis, that's a good option for them, as belimumab has long track record of efficacy in extrarenal lupus. In terms of safety, adding belimumab to standard of care did not increase the incidence of adverse events. So it is safe to add to standard of care therapy. For pregnancy, the use is not recommended yet, but hopefully further study will show safety in pregnancy. Okay, next question. You decide to administer a triple drug scheme to any case, whether voclosporin plus standard of care or belimumab plus standard of care. How long can you extend these therapies safely? Again, please use your cell phones to vote. Question A, option A is for the first 6 months, induction phase of therapy. B for 1 year and then taper. C for up to 2.5 to 3 years. D, these are lifelong therapies. E, not sure about any of the above. Please start voting. Again, how long can we extend these therapy safely? 6 months induction, 1 year, and then taper, 2.5 to 3 years. Lifelong, we don't know. Okay, so the majority voted for C, which is up to 2.5 to 3 years. And the correct answer is C. And this, so again, let's go back to KDIGO. What do they recommend? If the patient received triple immunosuppression for induction, then you may continue that with the maintenance triple immunosuppression. And when they started talking about induction, if you can see in the algorithm that was published, they mentioned that the CNI duration can be prescribed up to 3 years, and the belimumab duration can be prescribed up to 2.5 years. So let's figure out where did they come with these numbers. So first, for the voclosporin, using it for 3 years, it came really from the Aurora 2 study. So after completing the Aurora 1, that completed at 12 months, which was the phase 3, they had Aurora 2 study, which is an additional 2 years of voclosporin versus placebo. So they allowed patients who completed phase 3 to enter Aurora 2 for additional 2 years of voclosporin or placebo. And you can see here that at 3 years, their primary outcome was mainly safety, but also efficacy. We, as nephrologists, when we use calcineurin inhibitor, we are somehow worried about long-term nephrotoxicity. So this is an indirect metric, if we can say, clinical metric of nephrotoxicity. And you can see that the GFR was really stable over 3 years of using voclosporin compared to placebo. So it is kind of safe to use it for a total duration of 3 years. That does not mean that we have to use it for 3 years. We can use it less than 3 years, and that does not mean that we cannot use it more than 3 years. But the data that we have is over 3 years. What about belimumab? Where did the 2.5 years come from? So the BLISS-LN was 2 years phase 3 study, and they had an open label extension for additional 6 months. And over 2.5 years, you can see that in terms of safety, there was no signal of safety issue. So it was safe to use it up to 2.5 years. And also the PER, or primary efficacy renal response, and the complete renal response were maintained over 2.5 years. So these combination therapies allowed us to shift from the old regimen of induction and then maintenance to a continuous regimen of combination therapies that start with an induction phase and then move to a consolidation of response over 2.5 to 3 years. The last question, how long is the suggested total duration of immunosuppressive therapy in LN patients who achieved complete response? So please use your cell phone. It's about the duration of immunosuppression, total duration, induction and maintenance, or consolidation, we shall say, in patients who achieve complete response. A, 12 months and then taper or suspend. B, 24 months and then taper, suspend. C, at least 36 months and then taper, suspend. D, 60 months and then taper, suspend. E, not currently known. Please use your cell phone and start voting. So A, total immunosuppression for 12 months. B, 2 years. C, 36 months. D, 60 months. E, we don't have knowledge currently. All right, so the majority are between B and C, which are 2 years or 3 years of therapy. And the highest vote was for at least 36 months of total therapy. And this is true, it's at least 36 months and then taper, suspend. So we know from observational data that are published that if the patient receives about 18 months to 2 years, there is higher risk of flare compared to those who extended immunosuppression between 4 to 5 years. Again, these are observational data. There was a randomized controlled trial that was recently published in 2022, the WIN lupus trial, and this trial was done in a French cohort on immunosuppression discontinuation after 2 to 3 years of maintenance therapy associated with higher systemic and kidney relapses. Why is that? Because you can see here that the survival without renal relapses was higher in those who continued therapy compared to those who discontinued at 2 to 3 years. In terms of survival without severe SLE flares, it was higher in those who continued compared to those who discontinued. So again, continuing immunosuppression decreases risk of flare. If you stop immunosuppression by 2 to 3 years, there is higher risk of flares. So to summarize case 2, it is important that we individualize the selection of the best immunosuppressive scheme. And that's why the KDIGO guidelines, they provided practice points for specific scenarios. In our case, belimumab may be preferred in patients with repeated kidney flares and high risk of progression to kidney failure due to CKD. Triple immunosuppressive schemes may be continued for up to 2.5 to 3 years in terms of safety. And for the total duration of immunosuppressive therapy, we really still don't know, but we know that if we stop immunosuppression by 2 to 3 years, there is higher risk of flare, so we tend to continue for at least 3 years or more, depending on the risk-benefit of these patients. So individualizing the approach for a specific patient that we have in front of us in the clinic is very important until, again, we find biomarkers or histological guidance that is better than the available clinical metrics that we have. And with that, I would like to thank you, and we're open for questions.